Nathan, there's a number of different choices that we have, and we'll get into some of this in a second, but there are a number of different choices that we have for frontline therapy for patients with follicular lymphoma. But not all patients are the same. Some are older, some are younger, some have heart disease, some have other issues. You know, what factors make you want to use one therapy versus another?
Sure. So I think the difficult thing in untreated follicular lymphoma is that many things work, right? And so when you're looking at options, this isn't going to really be about whether a patient responds or not. It's about the toxicities, as you mentioned, that are associated with each individual regimen. So if you think about just a garden variety low-grade lymphoma patient that's not transformed, I think the common options in the United States would be really CHOP or bendamustine with rituximab. I think CVP less and less. And I tend to use bendamustine in pretty much most patients unless they have some comorbid condition, for example, heart disease, or they have some underlying, for example, peripheral neuropathy. I'm worried about vincristine. But I think in the garden variety patient, I tend to pick bendamustine in the majority of cases. That's really because I think most of the data from a couple different trials have suggested that bendamustine and CHOP probably are fairly equivalent with regards to controlling the disease long term. So yeah, again, I think that I don't really look much at the tumor burden, et cetera, when I'm deciding on different treatment options. It's more about the comorbidities that the patient has.
John, so this, I think this question of R-CHOP versus R-bendamustine, I figured with a few clinical trials that would have answered most people's questions, but it's still very controversial. Different people do different things. What do you do?
Well, I tend to similarly, but perhaps a little different. I put patients into three main kind of categories: those that I would give single agent rituximab to, those that I would use BR, and those that I would use R-CHOP. And I think we talked about the R-CHOP group already, the group that has concern for transformation in particular. And so, the R alone versus BR, I think it's nice for patients in that they can make a choice and you're not compromising their long-term outcome. It's clear that 2 drugs is better than 1 as far as efficacy. It's clear that 2 drugs are more toxic than 1 as far as safety. But at the end of the day, I don't know that we have any long-term data that suggests that if you start with BR versus you start with R and then use BR perhaps later, that is a difference. And so, and there are patients who have had, I have a number of patients who've had rituximab as a single agent and have gone 5 or 10 years not needing treatment. Now, those tend not to be patients with a lot of bulky disease, but certainly if somebody's been on watch and wait for a while, they've got cosmetic issues, they've got nodes that are, 2-3 centimeters, but have indications for treatment, those are people where I think rituximab alone is a reasonable option. But again, it's a trade-off, and the patient can choose. So I probably use a little more single-agent rituximab than Nathan at least described. But I think there's not a wrong answer, and I think a month of treatment, if you can have a meaningful remission for a period of time, as long as you know that you may be needing treatment again in another year or 2, or you may get lucky and go longer, I think that's a reasonable choice for patients to make. But I tend to use more single-agent rituximab in people that I've watched and waited for a while and are now kind of just crossing the threshold in that regard.
So, Josh, there's this new preparation of rituximab. It's given subcutaneously. It's much quicker. It's just 10 minutes versus 90 minutes or more for an infusion. Are you using it? And do you use it for everybody? Do you use it just for select patients? Tell me about it.
Yeah, it's a good question. So this subcutaneous rituximab with hyaluronidase is quicker, as you say. Just to clarify, all patients still have to go through their first dose of IV, standard slow titration of rate of infusion to see that patients tolerate well. And the patients that have really protracted infusions because of infusion reactions, we do not switch them over to subcutaneous rituximab because we want to be able to watch them more closely and make sure that they tolerate their second dose as well. And those are the same patients we all know that have infusion reactions, the high tumor burden patients. And for those patients that tolerate well, and we migrate some of them over, we've just started using it recently. It was a matter of accessibility, of having it on our formulary, of getting reimbursed easily. all practical things. But for those patients, yeah, a quick injection rather than a variable duration infusion. We have some places where we're comfortable doing 90-minute infusions on patients who have tolerated well in the past, and then literally other places in the hospital, literally some of the less familiar oncology floors still do 4-hour infusions. So yeah, a quick injection for the patient, very well tolerated in general. Some of these local injection site reactions, but really low grade, not so bad. Yeah, for the patient that is coming by to get his rituximab, his or her rituximab on the way home from work or something, that makes a difference between being able to do it on a weekday or having to take their Saturday to do it. So yeah, we've had good tolerability and a good experience with it overall.
Matt, the same in your institution, and specifically, is there any population that you treat with rituximab other than the people that are having infusion reactions that you wouldn't use it in?
Well, I think it's very interesting in that it makes sense that the NCCN guidelines would have put the footnote to allow it in other diseases like marginal zone lymphoma or mantle cell lymphoma, where it wasn't necessarily studied as well. So I think we were early. I would classify us as early adopters with the subcutaneous because our pharmacy put it in our into Epic, and we had to make a choice. Rituximab disappeared, and you had to choose: are you going to continue to give the subcutaneous, or are you going to give IV? So we had to have the conversation, and I think it comes down to another, spending more time describing the differences. And to Josh's point, if I have that person that has had infusion-related reactions in the past or uncharacteristic timing of infusions or weird things happening with the rituximab, I'm going to stick to the IV because it's tried and true. But to those people who want to spend less time, want to take less time off of work to get the rituximab, a half a day's vacation saved is well worth it. I think for a poke in the belly and some soreness, for a couple of days. So that's I've had discussions and I've seen on both sides where people come back and say, I'll take the IV back, or I'm comfortable with the subcutaneous moving forward.
And not just better for the patient, but we sometimes cannot book patients that the chairs are so full.
Right.
Getting the patient in and out of there in 25 minutes.
Yeah, I need that chair for the first dose rituximab patient,
Yeah.
that has an aggressive large cell lymphoma. So, and I agree with you.
Very convenient.
Yep.